Ready to chat with one of the most amazing providers in the entire country? Welcome to Jaw Talk with Dr. Tiffany. In this highly anticipated episode, I'm so thrilled to be able to host the extraordinary Dr. Rebecca Bockow, a true pioneer in the dental world. She's an accomplished orthodontist as well as a periodontist. Dr. Bockow's journey began at the prestigious University of Washington School of Dentistry, where she started as a general dentist and gained invaluable experience for 2 years. She then embarked on a unique dual specialty program at the University of Pennsylvania, seamlessly blending the art of orthodontics and periodontics. Her unwavering dedication and passion led her to become a board-certified expert in both specialties. Beyond her outstanding clinical practice, Dr. Bockow's influence reaches far and wide as she takes the stage as a renowned lecturer on periodontics, orthodontics, interdisciplinary orthodontics, airway, and skeletal growth and development, both nationally and internationally. Prepare to be inspired and enlightened as Dr. Rebecca Bockow shares her wealth of knowledge, invaluable insights, and remarkable journey in the world of dentistry. This episode promises to elevate your dental expertise and ignite your passion for the field. Don't miss out on this incredible conversation on Jaw Talk. Quick legal disclaimer. All information in this podcast is the opinion of the speakers and not meant to be a substitute for a diagnosis and consultation of a qualified healthcare provider. Hi, everyone. Welcome to Jaw Talk with Dr. Tiffany. I am so excited for my guest this morning. Dr. Rebecca Bockow is such a rock star in the orthodontic and perio and airway world. She is in my neighborhood and just a little bit north of me in the Bellevue area, so Washington State. So welcome to Jaw Talk, Dr. Bockow.
Thank you so much for having me, and thank you for all the work you're doing spreading the message too.
Thank you. So tell us a little bit. I was just looking at your bio. What an impressive background to go from restorative dentistry to ortho and perio. Tell us a little bit about your journey and what you're passionate about.
Sure. Well, thank you. So when I graduated from University of Washington Dental School, and University of Washington has a long history of interdisciplinary dentistry. And so I was exposed to these concepts very early on. And like many of your listeners, probably I was a dental CE junkie. So I finished school and was working in a phenomenal combined restorative perio practice and learned a ton and was just going to probably a study club a night, it seemed. Certainly a few a week, and couldn't get enough. In my patient care, as probably many of your listeners see, I saw a lot of breakdown in the adult dentition, and much of the breakdown that I saw had to do with a foundational mismatch. Either the bones or the soft tissue or the teeth weren't in the right place, leading to wear, leading to supereruption, leading to uneven gingival margins, not to mention TMJ issues, which is a whole nother topic. And I thought, after learning from a lot of interdisciplinary teams, I thought if I could help set up the foundation, that's really the role I wanted to play on the interdisciplinary team. And so I knew I wanted to go back to school. I learned that there was a combined perio-ortho program at University of Pennsylvania, and I thought if I'm going to go back to school, that's what I want to do. And so I was very lucky to be a part of the program at UPenn. And we focused a lot on setting up the bones, getting the bones in the right place, getting the teeth in the right place, and thinking really about the bone as a scaffold for the soft tissue. So really focusing on the system as a whole. And when I finished my program, I came back to Seattle, had an opportunity to sit through one of Jeff Rouse's courses on airway prosthodontics, and was looking at a lot of these adult patients that have sleep apnea. And I thought to myself, these patients have orthodontic issues. And it really all came together for me that there's this delicate balance, this system that we have to understand and respect. And it has to do with getting the bones in the right place, getting the soft tissue in the right place, getting the teeth in the right place, and making sure that that works with the tongue and the back of the throat and the cheeks and the lips. And to understand this dynamic system really is the key to setting a patient up for health. And so when I was in dental school, when I was practicing, for me, health had a lot to do with the shape and form of the teeth and the occlusion. But what I've really come to learn and respect is that so much of health has to do with how are the lips functioning? How is the tongue functioning? How is a patient breathing and sleeping? And of course, joint function. And to really understand this system and to create this equilibrium is really the key. And so that's my journey in a nutshell.
Yeah. Well, and I think the whole paradigm of dentistry is really changing where we're becoming more airway centric, airway aware. And when we see that mismatch between the maxilla and the mandible and how certain phenotypes, let's say like a class 2, really retinopathic profile, how that really can impinge on the oropharyngeal airway space, I think that dentists are excited about looking at airway and looking at kind of that bigger lens of things.
Absolutely. And so as I think about how this flavors how we practice, when I first started practicing as an orthodontist, because of the specialty training I underwent, I saw a lot of adult patients
Mm-hmm.
and started to realize that a lot of the adults, we can talk about TAD expansion if we're talking about the transverse, but if it comes to AP issues, a lot of the solutions really are surgical, which it's a privilege, it's an honor to be involved in the surgical cases, and we do a lot of jaw surgery as part of our interdisciplinary treatment planning. But what's really exciting to me is thinking about guiding growth.
Mm-hmm.
And we have an adult, we have the breakdown, we have the symptoms. Can we take that same patient and catch them when they're 5, 6 years old or earlier? And what does intervention look like? And how do we guide growth to establish health early on so that we don't end up with some of the problems that we all see in our practices on a daily basis? And that's a big interest of mine is how do we hone those systems, how do we identify those patients, how do we guide growth.
Absolutely. And what I'm seeing, not so much in my practice because I'm kind of like you, I see more of the adult patients that now have had such extensive breakdown of their TM joints. They may have a lot of headaches or, jaw dysfunction, maybe limited range of motion. And I think it's so exciting if we have kind of like that crystal ball of like the future. I think probably like as a mom too, you may be looking at your own kiddos in a different way when you're starting to say like, oh hey, we're not going to wait until like they're 12. We want to be in kind of more of that interceptive phase. So would you say like what's the ideal age range for a kiddo to come see you?
Well, it's a great question, Tiffany, and I don't know that I have a 100% answer. I think though, as orthodontists, we can redefine how we what do we determine as intervention. So,
Mm-hmm.
for example, let's say we have a thumb sucker, and I've had patients in my practice, and they come see me, and they're 7, and they say, "Oh, the pediatrician said not to worry about this until the adult teeth come in."
Mm-hmm.
But if we take a big step back and we think about all the things that happen with thumb sucking, first, it holds the tongue low. And so we think about the muscle memory and we think about the swallow and we think about all the functional aspects of the tongue. Suck, swallow is what determines the width of the palate. Also, bringing that tongue forward helps bring the mandible forward. And so, all of this, just holding the tongue low, it's going to impact speech, it's going to impact functionality. As we push up in the palate, we get a high vaulted narrow palate, which in turn leads to smaller, undersized nasal passages. And so we have less tongue space. We have a high vaulted palate. We turn this patient into a mouth breather if they can't breathe efficiently through their nose. And then lastly, we're holding the forward growth of that lower jaw back. And we think about that condyle in the fossa during these early formative growth years. Is the disc truly going to be established and growing on the top of the condyle? What have we done to growth of that lower jaw? And so now here we have a patient, they're 7 years old. We have 7 years of lack of forward development to the lower jaw. Now they present as crowding because the jaws are small. And now we have to talk about intervention. And so maybe intervention is helping understand the habits early on, really establishing these patterns of lips together, tongue up, quiet nasal breathing for these young kids, and really start to think about the system as a whole. And so if let's say we do catch them at 7, well, it's not too late. We'll take them whenever we can get them, but then at 7, it's not just widening the maxilla, it's not just uprighting the lower teeth, but how do we now retrain the tongue? How do we incorporate myofunctional therapy? How do we reintroduce some of the things that we've been lacking for these 7 years? And so we can redefine interdisciplinary intervention, and then we can really start to help guide growth. I think the same thing with crossbites. So the AAO, I think it's misunderstood. They say see the orthodontist prior to age 7. And so so many orthodontists say, well, I don't want to see them until age 7. I don't think there's any magic about age 7 per se. In our practice, we can intervene whenever that patient really is mature enough to sit through the appointment. But even if, so let's say we have a 3-year-old or a 4-year-old, if they're not ready to see us, maybe it's helping them find a myofunctional therapist. Maybe it's getting them to see the allergist, the ENT. What's leading this patient to be a mouth breather instead of a nose breather? And are there things we can do early on to intervene? Like you can have a 4 or a 5-year-old and their palate is so narrow that their tongue doesn't know where to go. And it impacts speech, and it impacts chewing and mastication. And so I know your expertise is on the TMJ, and we think about condylar growth and the importance of function early on. And if they're slip sliding that lower jaw in every which way, and they're compensating in the chewing cycle because they don't quite know where to position their tongue, we have to start to question, what is that doing to the shape and development of the fossa of that fibrous disc, of all of this muscle memory and all the importance of development of the jaw early on. So I don't have all the answers. I know you asked at what age do we intervene. I don't know that I have that answer, other than we have the ability as dentists as a whole to identify some of these things happening early. And if we don't have the tools in our toolbox to be the person to intervene early, at least we can help these families find the right resources.
Right, right. And sometimes collaborating with, let's say, like an ear, nose, and throat physician or a sleep physician, maybe getting some type of a sleep study.
100%.
Yeah.
Right. SLPs, myofunctional therapy. If they need a tongue tie release, trying to help them get that early on. Even looking at infants, helping mothers find the right resources to help them successfully breastfeed. Breastfeeding is so positively impactful to growth and development. And so really thinking about these kids as a whole, and not just thinking about when do we line up the teeth. Because I think we miss a lot if we just focus on lining up the teeth.
Absolutely. Absolutely. And from my PT perspective, I also, I'm all about like posture and, looking at
Yep.
hypertonicity of like the neck, I know, sit up straighter, but what we're seeing too is also, kind of the PT part of me is also looking at the cervical spine. And, when you're starting to do more modern imaging, let's say, maybe a full field of view of cone beam CT, maybe MRI of the TM joints or of the cervical spine, depending on the patient and how they're presenting. But we're seeing, a lot of rotation sometimes in like C1 or Atlas. And then you'll start to see, movement dysfunction. And like you said, the underlying skeleton really provides that framework for the musculoskeletal system.
Absolutely. Well, and then to take that a step further, if the bones are in the wrong position, and or if there's some sort of myofascial tightness, we start to see compensations. And those compensations to speak and to swallow lead to stress on the muscles and stress on the system. So you go back to your underbite patient that you alluded to earlier. Maybe that patient was a thumb sucker. And now here they are at 11 or 12 or 20 or 40, and they have to shift their lower jaw forward to bring their lips together to swallow a bolus of food. to speak, to function, and what stress and strain does that put on the system as a whole. And so the position and development of the bones is so important, once again, to this equilibrium.
Absolutely. Yeah, absolutely. So, what does kind of like a workflow look like in your practice? If you do, let's say you do have that young kiddo that's coming in that, maybe you're wanting to work with habit elimination, maybe you're wanting to look at, some interdisciplinary workup. What does that look like?
Great question. So let's say we have a 7-year-old that comes in, and an easy example might be narrow arches. And so we use the Shervin Pediatric Sleep Questionnaire. There's many screening tools out there. There's many sleep questionnaires, but this one is a really easy one for parents to look at. And it's a conversation starter. It helps us identify, is this a patient that has some concerns beyond just, let's say, crowding?
Mm-hmm.
And so we start talking to the families about what is the patient presenting with. Sometimes they're very well informed and educated. Sometimes they're coming in just because there's crowding. And we take a low radiation, low voxel CBCT just as a screening tool. And we start to talk and we start to identify what's going on with what we see radiographically. If we identify narrow arches as part of the problem, if we also screen for tongue ties, and we look at myofascial compensations secondary to things like tongue ties, like narrow arches. We also try to identify low tone, because sometimes it's not a tongue tie, it's lack of muscle development, lack of muscle memory. And so, if there truly is a patient that is symptomatic, if there is a patient where the diagnosis truly is undersized jaws, then we talk to them about expansion is one option. On the lower arch, we often decompensate the teeth, so we're doing a lot of dental uprighting. On the upper arch, we'll do skeletal expansion. We often use a Hyrax expander. That's our workhorse in our practice. Once we've created that space, that's when we start incorporating myofunctional therapy. So when the expanders come out, we'll send them to our myofunctional therapists. We work with a great number of phenomenal myofunctional therapists all over the King County area. And if that's determined, now sometimes all they need is some help with muscle memory, function, stretching, strengthening. And if that's all they need, that's where their journey ends. If the myofunctional therapist determines that there's a tightness such that they would benefit from a release, then we'll help identify providers that are well trained and well educated on a release for these kids. If the child has apnea, or we suspect apnea, we'll refer to sleep medicine. If we identify enlarged adenoids and tonsils, we'll refer to ENT. We also ask a lot of questions. Maybe they didn't know that they should get an allergy screening, so we'll refer to allergists. So we work very closely with the pediatricians in the area. And so it's really exciting. It's redefining interdisciplinary care. We can identify kids that maybe need help with diet and oral hygiene. So we work very closely with our pediatric dentists, our restorative dentists. And so when I was practicing as a restorative dentist, our interdisciplinary team, we were looking at implant placement and gingival margins and these sorts of treatment plans. Now we have an interdisciplinary team, but we're made of different specialists, and it's very, very exciting. And so we're talking constantly. Does ENT come first? Do we come first?
Mm-hmm.
Do we need oral hygiene instruction first? And so really making sure that everything is tailored to every child. I think, Tiffany, another important part that we should mention too is that we can't overpromise. And so we all need to work together. We all need to have a really solid diagnosis and understanding of every child and an adult too. And we can never promise, for example, that expansion is going to magically cure sleep apnea. We can't say that. We don't know that to be true, but we do know that we play a role. We play a role in that interdisciplinary team.
Absolutely. And what would you say? I'm just going to play the devil's advocate here a little bit about someone who has, reservations about maybe doing more of that modern imaging You mentioned, the cone beam CT technology has really improved where you have a very low dose radiation. In my practice, like I said, there's times where I'm getting the patient a little bit later in life, maybe like 12, where they've already gone through their expansion, and let's say we're starting to see maybe some condylar degeneration on the CBCT, or maybe they're starting to have some clinical symptoms of clicking and popping or headaches. And then one of the things that I have learned from my mentor, Dr. Jim McKee, is also for certain patients, also bringing in an MRI protocol. I learned from also Dr. Mark Piper, some of his different bite registrations and working with, a radiology team to sometimes be imaging the TM joints and seeing, is that articular disc, kind of still covering the growth center, or are we looking at a disruption to the disc ligament system? Is that something that, like, how do you feel about that?
Yeah, it's a great question. I know it's an area of controversy for sure in our profession. And I think for all of us as providers, we want to do the lowest amount of radiation possible at every time we're interacting with a patient. And so if we have, let's say, a recent pano from a provider, and it gives us enough information, there's times where we don't take any additional imaging. The only time we would take imaging is if we truly felt it to be necessary for the diagnosis and treatment planning of the patient. When we do take our x-ray, we take the smallest field of view possible, and we do the lowest resolution possible to see what we need to see. So an endodontist or a restorative dentist would hate our images because they're relatively fuzzy. We just need to see sort of big picture, and we don't need this high resolution. So really trying to limit and lower the amount of radiation that we use in our day-to-day x-rays. But I think to that point, I think we gain a lot of information more so than we would otherwise. We're often the first people to pick up adenoids and tonsils. We pick up impacted teeth. We sometimes pick up supernumerary teeth. We can talk to these patients about things like adenoids and tonsils. Some of these patients have already seen the ENT, and the ENT did not use an endoscope for whatever reason and has given them the clean bill of health, only for them to come see us and we see a partial or sometimes a complete obstruction up at the adenoid pad. And these sorts of things are only seen otherwise with an endoscope. So we're providing data in a way that maybe we couldn't otherwise. We're identifying deviated septums. When it comes to joints and joint pathology, certainly we can pick up things that we wouldn't have seen otherwise, lack of joint space, joints that are repositioned, and in the older patients, picking up things like degenerative joint disease.
Mm-hmm. Yeah. Well, and I think that, like you said, being very mindful of, using that modern imaging in a way that makes sense for that particular patient is really key, but also not being afraid of, as a general dentist, starting to kind of push forward with the tools that we're given. You think about how endodontics has changed with, being able to utilize cone beam CT and, being able to see things with a microscope. So, we're pushing forward in that microscopic level, but also, maybe taking a step back out and seeing things from, that bigger lens where, like I said, you're looking at, where it's not just the bite and how the teeth fit together, but you're looking at the jaw development as well as, the airway and like I said, and I love to bring in the cervical spine piece of it as well too, because I think that that's part of it. And a lot of times in these younger kiddos, they may not have pain and dysfunction, but you can start to see subtle signs like we talked about, either postural changes or maybe changes in the fascial system, one side versus the other. And I think it's exciting that oral myofunctional therapy is really coming to the forefront, where you have, like you said, speech pathologists, PTs, OTs, really excited to learn and collaborate. And I see that as the future of, we all need one in our office
Yeah.
or a
Oh,
team member.
yeah, yeah. No, we can't do. I take this from Barry Raphael, but he talked about structure, function, and behavior. And so, as the orthodontist, we're the structure people. We can help mold and shape and guide growth of the bones. Function is, can a patient breathe through their nose? Can the patient get their tongue up? Can they keep their lips together? And then finally, are they doing it on a habitual basis?
Mm-hmm.
And so that's really where the interdisciplinary team comes together.
Yeah, that's so exciting. So, who would you say kind of has one of the better education systems for OMTs? I know Dr. Zaghi has the Breathe Institute. They have a tremendous program, but if we have a general dentist that's listening to the show that is wanting to maybe have a team member train, maybe they have a dental hygienist that's excited about OMT, who would you recommend for educational systems?
Gosh, Tiffany, I don't know that I know all the different courses out there, to be honest. I've heard a lot of great things about a lot of the courses out there. I don't know the difference, to be honest.
Yeah.
So I don't
Yeah.
I don't know that I'm the best person to weigh in on that.
Well, I just snuck that question in. I mean, I did some training with the AOMT, and I think that they have a fabulous program. And like I said, I think the Breathe Institute and their Myo Masterminds. So it's exciting to see that. When I spoke last November at the Pacific Northwest Dental Convention, which is one of our big meetings here in Washington State, I was like mobbed with dental hygienists that said, "Okay, where do I go? I want to be an OMT." And so
I love
I think it's really exciting to see that kind of enthusiasm and that kind of collaboration in our field, even of dentistry. So
That's great.
yeah, yeah. So, as you have kind of for me, I think that, like I said, when I was a mom and kind of like walking through some of the things that I'm seeing with my kiddo, and just starting to like recognize how all of these things with airway and myo and the joints and the growth and development of the craniofacial complex, how those all come together. I think sometimes as a parent, you become like overwhelmed because there may be other issues also at play. Maybe there's signs and symptoms of disrupted sleep. Maybe there's problems at school with maybe behavior or like concentration. Where do you kind of direct parents if they're seeing some of these signs and symptoms of like disrupted sleep, or like you said, mouth breathing, or maybe, some symptoms of like wetting the bed, or some of those things? Where do you try to direct your parents when they're like, I'm so overwhelmed with all these things, like where do I start?
Yeah, it's a great question. Well, if they're seeing us and we identify that there's a true skeletal deficiency, then we talk to them about guiding growth. We talk to them about early intervention. Yeah, we refer very often for sleep studies, and that gives us a piece of information. It lets us know their baseline. We'll
Mhm.
refer to ENTs. The literature says that the number one way to help with some of the things you mentioned is to have adenoids and tonsils removed if it's needed. We have also shown that adenoids and tonsils can shrink with expansion alone. And so some families choose to try expansion before they see the ENT. And we certainly help guide them on which direction to go. Sometimes they'll see the ENT for a consultation and then make a decision which way they want to go. And some will choose to try some more conservative options like Flonase combined with an air filter, combined with a humidifier, maybe with a breathe right strip, trying to keep pets out of the bedroom, trying to avoid dairy because that's been shown to produce mucus, and trying to be really conservative with our interventions, trying to see if we can help the body shrink that tissue on its own. But but certainly we can't promise that that's going to happen in every case.
Mhm.
Whenever we do an intervention, especially if we started with a positive sleep study, we'll recommend it as a follow-up at the end of our treatment, because we truly want to make sure that we've helped these kids get healthy, and if they still have underlying apnea, they certainly still need intervention.
Mhm.
And that's really the power of these interdisciplinary treatment plans.
Absolutely. Well, and I think as a former PT, when we would have complex situations, let's say a neuro patient, you definitely love collaborating with your SLP and your OT. And, I think that as dentists, we kind of get a little bit siloed into our, practices and, trying to keep up with the whole team. And I love that like I said, I love the enthusiasm of the OMTs that I've come in contact with and how they really want to work together with the general dentist and the orthodontist and really just help our patients get the best outcomes possible.
Absolutely.
Yeah. Yeah. So tell us a little bit about, you do a lot of lecturing and education. Tell us a little bit about, kind of some of the things that you have coming up in the future.
I feel very lucky to have the opportunity to lecture both locally and also nationally. So there's various dental conferences that I've been asked to speak at. I've spoken recently for ACT Dental. I'm speaking at PNDC next year, like you did as
Wonderful.
well. I'm speaking at for Spear Education a few more times this year. One course I'm really, really proud of to talk about and really excited about is a course that I do once a year with Dr. Michael Gunson. Dr. Gunson is a phenomenal oral surgeon, and through working with him, we both really love teaching together because we learn from one another, and it's really an incredible course that looks at the entire spectrum of growth from childhood issues all the way through adulthood. We focus a lot on early intervention. We look at joints, we look at connective tissue disorders, we talk about the importance of lips coming together, we talk about speech patterns and their impact on growth as well as on breakdown. And then he also focuses a lot on surgical interventions to help rehabilitate the patient. So it's everything: cross bites, underbites, open bites, underbites, gummy smiles, joints. It's everything. And it's 3 days, and it's in October in Kirkland, Washington.
Awesome. I have to be there.
Oh,
It's going to be so good.
it's really fun too because we keep it small. So the small group conversations, I think we learn as much from each other as we do from the person that's giving the talk. So that
Absolutely.
makes it really fun.
Absolutely. Well, we'll definitely put the link for that course in our show notes and just really encourage people, if you're listening and you're in that greater Seattle, Tacoma area, this is a must attend for
Oh,
sure.
thank you. Thank you.
Yeah. Yeah. And then again, tell me like a little bit about, you had said in your practice you utilize your oral myofunctional therapist. Are you also incorporating any type of like body work as far as like myofascial release or working with maybe like a PT on postural retraining, or, are you utilizing someone as part of like your interdisciplinary team for kind of the musculoskeletal component?
I think it's really important. I think we often refer out. It's not something we have in the practice, but it's so important. I mean, and I think for the kids and also for the adults, we had an adult yesterday, and we finished TAD expansion and protraction, and she loves how it feels. She loves the tongue space. She loves her ability to breathe through her nose, but she said she still feels like she's retraining her muscles and her tongue how to work. And
Mhm.
so working with her chiropractor, working with her PT, working with some, and I even talked about working with a craniosacral therapist, because for some people they catch on right away, but for others they really need some help trying to learn how to retrain their whole skeletal muscular system. Like you talked about, just posture, and it's all so interrelated. And after jaw surgery too, I mean, we fundamentally are changing the position of their jaws, and so
Absolutely.
really helping them reestablish muscle patterns, muscle strength, really important.
Yeah, yeah. Well, and I think your model of practice is something that we're going to see, throughout, all practices, I think need to have an interdisciplinary team like what you've established. I think it's so important to not be afraid to talk to your sleep medicine providers and your ENTs and start to find your people in your community that you can really learn from, and kind of that, pushes forward your growth as well as a healthcare provider and as a professional.
For sure.
Yeah, wonderful. So I had a little like spicy question. I'm seeing on, social media, there's always like a lot of like misinformation about orthodontia. What would you say is like the biggest myth that people on social media get wrong about ortho?
I think one area that's sort of an interesting hot topic right now is there's people out there, not necessarily orthodontists, that say that premolar extraction causes apnea.
Mm-hmm.
And I think that's incorrect.
Mm-hmm.
I think if we think back, so let's say we have a 12-year-old in the practice and they're so crowded that by the time they see the orthodontist says, there's no way I can line up your teeth without taking 4 teeth out.
Mm-hmm.
Well, let's take a big step backwards and ask the question, is it that there's too much tooth structure, or really is it that there's not enough bone? And if that's the case, maybe looking a little bit deeper, is there a breathing dysfunction? Is there a tongue dysfunction that led to the small jaws in the first place? Because chances are, not always, but chances are, that teenage patient had some sort of breathing or tongue dysfunction long before they saw the orthodontist. And so taking out 4 teeth, it just maintains what they came to the orthodontist with. The orthodontist didn't treat it, didn't make it worse. The orthodontist lined up the teeth. But what's really exciting, Tiffany, is asking new questions. Because if you take that same patient and you start to look and ask questions about breathing and tongue and size of the jaws, if you determine that truly they do have smaller jaws, if you determine that they have a breathing or tongue dysfunction, then now all of a sudden we can treat that in addition to lining up their teeth. And now you've made the patient healthier. If you catch that same patient when they're younger, that's even easier and better, I think.
Right, because like the bone is very malleable, and your range of choices of treatment are probably, you have more options at that point.
It's so much easier. Well, and then let's say, and we're making assumptions here, but let's say that 12-year-old had some sort of sleep disorder, maybe. And so if you treated that same child at age 6, now you just gave that child 6 more years of better sleeping and breathing. And you corrected a lot of the myofascial issues early. So there's a lot of benefits to catching these early. But it's asking the right questions, it's having the right diagnosis, it's intervening when it's appropriate. And that's the other thing that I see on social media is I think that some of these concepts can be overused. They can be underutilized, and then also sometimes people are doing this without maybe proper diagnostic records and proper information.
Absolutely.
So it goes
Sometimes we
both
have to
ways.
go down and get the diagnosis, right?
Yeah.
Yeah, yeah. Well, and one of my things is also just stay humble, stay curious, because the literature is always changing. Our understanding of, how different things impact us, all of that is changing, and we need to be open to new concepts, and 100%.
100%. 100%. I think we're learning daily, weekly, monthly, and how we practice today is different than 2 years ago. And I don't have all the answers. None of us have all the answers, but we're all on this path to learn together.
Well, you're certainly a rock star in your profession, Dr. Bockow, and I just feel like I feel so privileged to be able to talk to you and spend this time with you. So thank you again, and let people know kind of where to find you, and we'll put those links also in the show notes.
Amazing. Well, thank you so much. Well, I'll give you our practice page and our Instagram handles. And certainly, if anyone that wants to stay in touch, please stay in touch.
Wonderful. Thank you so much.
Thank you so much.
There you have it, another great episode of Jaw Talk. I hope this has ignited your passion for dentistry and really reinforced your commitment to achieving optimum, comprehensive, healthy care for our patients. To continue receiving captivating insights and valuable discussion, make sure to subscribe, review, and leave a comment on your favorite podcast platform. If you're eager for even more exclusive benefits and want to support the growth of Jaw Talk, please consider being a valuable member of our Patreon community. Visit the link in our podcast description to join today. Your involvement in our community truly makes a difference in shaping the future of our show. We appreciate you as being part of the Jaw Talk podcast family. So stay tuned for upcoming episodes featuring more brilliant guests and thought-provoking content. Thank you so much for being with us on this journey of dental exploration in the world of airway plus myo plus TMJ. Remember, stay humble, stay curious, and we'll see you next time.